Hi everyone, good morning. We'll get started so we have enough time for a grand round. It's a real pleasure to have today Dr. Antonio Gotto, who is an iconic figure in lipidology and cardiology in general. So for our fellows that you may not know him, he's really a big deal in lipids. So it's a real pleasure to introduce him. Dr. Gotto is Dean Emeritus of Weill Cornell Medicine in New York, where he's also a Provost for Medical Affairs Emeritus at Cornell University. From 1997 to 2011, Dr. Gotto was the Stephen and Susan Weiss Dean at Weill Cornell and Provost for Medical Affairs at Cornell University. What you don't know is that he rise very fast. He was Chief of Medicine at the age of 40 at Methodist and Baylor. At that point, they were together. And then after 20 years there, he was recruited to be the Dean of Cornell at age of 60. So extremely young for that position. His postgraduate work included doctoral studies at Oxford University in England as a Rhodes Scholar and residency training at the Massachusetts General Hospital in Boston, Massachusetts. In the field of atherosclerosis, his basic science research interests include clinical disorders of lipid transport and the structure, metabolism, and function of lipoproteins and apolipoproteins. Dr. Gotto and his associates were the first to achieve complete synthesis of a plasma apolipoprotein. They also determined the complete cDNA and amino acid sequence of ApoB100, one of the largest proteins ever sequenced and key protein in atherosclerosis. He has played a leading role in several landmark clinical trials demonstrating that cholesterol-lowering drug treatment can reduce the risk of heart disease, with publications in top journals such as New England Journal of Medicine, Lancet, and you name it. He's also the editor-in-chief for Current Atherosclerosis Reports, a journal that we enjoy, that we publish and we read often. And he was telling us yesterday that he's still seeing patients here in New York. So it was a real honor to meet you yesterday for dinner and to enjoy the vitality, and energy that you have. Thank you very much.
Thank you very much for that kind introduction, and nice dinner last night. Thank you, Dr. Marcos, for inviting me. So it's a pleasure to be here, and I'm going to cover the history of cholesterol from very early stage up to the present. First problem is getting the
That's there.
So this is an outline of the history of cholesterol, first identified in bile back in the early 1800s. And the individual who identified it, or he gets credit for it, was one of the 80 people who had his name on the Eiffel Tower when it was built. However, it wasn't for discovering cholesterol. He was a chemist, and he made dyes for the for the company that makes carpets. And so that's why his name was there. But at any rate, then human atherosclerotic plaques was shown to contain cholesterol. A Russian doctor named Aneshkov fed cholesterol to rabbits and showed that it produced lesions, and he actually identified the lesions in the arteries of the rabbits. He was a Russian, and he did this work in Freiburg, who his mentor was Dr. Aschoff. Those cardiology fellows, do you know who Aschoff was and what's named for him? Aschoff bodies, which are supposed to be pathognomonic for rheumatic fever. But at any rate, he was there in 1914 when the war broke out, so he got arrested as a Russian and put in prison. But Ashok managed to get him out of prison, and he went back to Russia and joined the army, and he was really in the military after all the rest of his life. But let's go down to 1938 when familial hypercholesterolemia was described. And then 1954 when elevated LDL was shown to be the primary focus in familial hypercholesterolemia. And then the biosynthesis of cholesterol was elucidated and shown that HMG-CoA reductase was a rate-limiting step, which turned out to be very important. And FH has both heterozygous and homozygous forms. And down at the bottom, the LDL receptor concept was defined, which is a very critical point in metabolism, clearance of LDL from the blood. And then statin effects were described in fibroblast animals and FH in 1976. Well, angina pectoris was linked with hereditary xanthomatosis. And Dr. Mueller, Carl Mueller, that in 1939 observed my first patient with xanthoma tuberosum and angina pectoris in April 1937. By June, I was able to make a preliminary report of a number of cases in which I expressed the opinion that hypercholesterolemia is a frequent and important factor in heart disease. This opinion has been strengthened beyond expectation by the study of additional patients. So here we have linked together an inherited increase in cardiovascular disease, xanthomas, family history. I'll skip forward to 1949. Dr. John Goffman was a biophysicist at the University of California in Berkeley. Used an ultracentrifuge to separate lipoproteins based on the rate of rotation. The more fat they had, the larger the particles, such as chylomicrons and VLDL, they would float to the surface faster. They were what we described as Spinberg groups, which measured the rate at which they came to the surface. And he was able to show that in familial hypercholesterolemia, the lipoprotein particles that were present and elevated were LDL and IDL. LDL and IDL are made from VLDL, which is secreted by the liver, and then lipoprotein lipase and hepatic lipase break down the VLDL particles to LDL and then finally LDL. The Framingham study was sponsored with the NIH, Heart Institute, and started in Framingham, Massachusetts in the 1960s. And it was shown that increases in LDL increased cardiovascular risk, whereas elevations, high levels of HDL appeared to be protective. And the Framingham study also identified high cholesterol, high blood pressure, cigarette smoking, and diabetes as the four major risk factors for cardiovascular disease. 1976, Mike Brown and Joseph Goldstein described the LDL receptor. And this is crucial to understanding the mechanism of many of the cholesterol-lowering drugs. The LDL binds to a receptor. The LDL has positively charged amino acids, asparagine and arginine, which bind to a negatively charged glycosaminoglycan within the receptor. And then the LDL particle is taken up by a process called endocytosis. It's degraded in the lysosomes, and it helps to regulate microsomal enzymes. As you accumulate more cholesterol, you decrease the activity of HMG-CoA reductase, because you don't need to make so much cholesterol if you already have a large amount in the liver. These are drugs that work through the LDL receptor: bile acid sequestrant, statins, ezetimibe, PCSK9 inhibitors, and bempedoic acid. In 1976, Dr. Akira Endo isolated the first statin as a fungal metabolite. Dr. Endo was trained in Japan, but he came to learn his microbiology at Einstein. And then he went back and joined the Sankyo company and started looking in fungal metabolites to find inhibitors of HMG-CoA reductase, which is a rate-limiting step in cholesterol biosynthesis. And the first two were isolated as fungal metabolites, pravastatin and pravastatin. And the characteristics are the decollage structure, and then a side chain, entity here, and then a side chain. And this side chain looks like HMG-CoA reductase, and it fits into the place where the HMG-CoA reductase bind is active. And so these were the first two statins that were discovered and described. Notice that lovastatin and simvastatin in the side chain that's responsible for the inhibition of HMG-CoA reductase have a lactone structure, a closed ring structure, whereas in all of the other statins, they're open structure. This is a prodrug, then it has to be opened. Lactone has to be opened in the intestine to be active. And then simvastatin differs from lovastatin only it has a carbon group instead of a hydrogen. And then we have fluvastatin, which was very active in fibroblasts, but not so active in humans. And the two major statins have been atorvastatin and rosuvastatin. Rosuvastatin has a SO2 structure in it. It is more hydrophilic. Atorvastatin is more hydrophobic. Finally, pitavastatin, which has a cyclopropane structure attached to it. It's active, its efficacy is high. Can use it at very low concentrations, but total magnitude of LDL reduction is not so high, so it's considered a moderate activity statin. And in the cholesterol biosynthesis pathway, HMG-CoA reductase is a target for statins, and two steps up above it is bempedoic acid, which is an inhibitor of ATP citrate lyase, and it inhibiting bempedoic acid will decrease acetyl-CoA, which is required for cholesterol biosynthesis. So they're both in the same pathway. They require the HMG-CoA reductase activity in order to decrease cholesterol and ultimately LDL levels. Cardiologists were very skeptical about cholesterol lowering. Michael Oliver was one of the most outspoken, outstanding cardiologists in Edinburgh, a good friend of mine, but he didn't believe in cholesterol lowering. And he said, even if you lower it, it's not going to make you live longer. But study that disproved this and finally convinced cardiologists that it was worth paying attention to cholesterol and trying to reduce it with the simvastatin study. These were patients who already had established cardiovascular disease. 20 to 40 milligrams of simvastatin gave a 37% reduction in LDL. But the thing that really convinced the cardiologist was a 30% decrease in all-cause mortality. That was the gold standard. And after that, cardiologists took up the use of statins vineyards. 80% of cardiologists I know are on a statin. I was chair of the FCAPS TexCAP study. This is a primary prevention study with lovastatin. These were individuals who were at military base in San Antonio and then another hospital in Fort Worth. They were very healthy. During the course of the study, we had a man named Eli Whitney who drummed into the importance of diet and exercise. And they were extremely fit people, individuals. Their average LDL was 150. But in 5 years of follow-up, it was a 37% risk reduction. So whereas simvastatin showed that you could reduce cardiovascular events in secondary prevention, patients with established disease, FCAP's TexCap showed the benefit in primary prevention, but in primary prevention where the people were also doing all they could with diet and exercise. Dr. Paul Richter and I did a post hoc analysis of the FCAP's TexCap study. And what we found was that if the LDL was below the median, or the CRP was high sensitivity CRP was below the median, or both were below the median, then there was benefit. But if above the median, there was benefit. If both of them, both the inflammatory marker as well as the lipid marker, if they were both already below the median, they didn't get any benefit from the statin. But this, I won't have time to go into the role of inflammation, but the inflammatory factors act independently of the LDL reduction. And in fact, in one of the studies Dr. Richter did, there was no reduction in LDL, but 15% reduction in individuals who had an elevated HSCRP. Well, Dr. Richter then led the Jupiter study, in which individuals were, to get into the study, you had to have a HSCRP over 2 and one other additional risk factor. But it didn't matter what your LDL was. And based on the results of this study, where there was a 44% reduction in events and the study was terminated early, the FDA approved the use of rosuvastatin in individuals, males at earlier age and females. One additional risk factor was required, but with an elevated HSCRP, regardless of what the LDL was. The group in Oxford has led meta-analysis study in which it was shown that for every 1 millimolar reduction in LDL, that's 39 milligrams per deciliter, all of these measures of cardiovascular risk and benefit were reduced, with one exception: hemorrhagic stroke. It was the effect there was neutral, and all of the others, ischemic stroke, any major event, was a 22% reduction for 39 milligrams per deciliter reduction in LDL. Today we push LDL levels even lower. The risk of events have been shown to decrease all the way down to 50 milligrams per deciliter or lower. You see television advertisements now for Amgen recommending getting the LDL down less than 54. So the point here is that lower seems to be better, and at very low levels, which were obtained in some of the PCSK9 studies that I'll talk about in a few minutes, were not associated with any side effects. Ezetimibe works through the LDL receptor. Cholesterol that's in the GI tract is incorporated in cell membranes. It's bound by a factor called PIC-T1-like-1. And then this interacts with something called a clathrin complex. And when this occurs, then cholesterol is taken up by the cell, by the hepatocyte. However, ezetimibe blocks this interaction between NBC1-like-1 and the clathrin complex, so it doesn't get taken up by the hepatocytes and is lost in the intestine. The improvement trial looked at ezetimibe on top of simvastatin. These were patients who had an acute coronary event within the last 10 days. They were given simvastatin 40 or simvastatin 40 plus ezetimibe. The baseline LDL was 65 and 53.7 in the simva and ezetimibe. If you look at the curves, you see there's no diversion or separation of the curves up to 3 years. The study had to go on for 6 years in order to get enough events to have be able to interpret the results of the study. And what was observed was that there was a significant LDL or cardiovascular reduction. That was 6%, and the number needed to treat to prevent one event was 50. However, the FDA didn't consider a 6% reduction clinically significant enough to approve it. So ezetimibe, to this day, doesn't have a cardiovascular risk reduction indication. It is indicated for lowering LDL. But if you look at the curve, the yellow border, improvement falls on the same curve as with the other drugs and other measures to lower LDL cholesterol. And so it has a similar risk reduction in MACE for each unit of LDL reduction, same as statins. Now we turn to PCSK9, a group in France led by Barrett in 1999 identified a French family who appeared to have familial hypercholesterolemia. However, when they did a whole genome sequencing, they didn't find any mutations in the known FH genes. And Dr. Helen Hobbs and Joseph Cohen and colleagues in Dallas looked at individuals who had very low levels of LDL, and they found that with certain mutations, loss of function, it's a gain of function, in African Americans on the far right, there was over 80% reduction in cardiovascular events in these individuals with very low levels. So this was a stimulus for pharmaceutical companies to make inhibitors of PCSK9. PCSK9 is a protein that is secreted, targets LDL receptor for degradation. Gain of function mutations cause a high level of LDL, and loss of functions cause a low level of LDL. Inhibition lowers LDL levels. And this is a cartoon showing the LDL receptor on the surface of the cell. And then over here you see the LDL on the receptor, but with a little crooked structure, which is PCSK9. And so when the PCSK9 is attached to the LDL and to the receptor and is internalized, it targets it for destruction or breakdown. Here you see the uptake of the LDL particle on the receptor with PCSK9 attached. And it gets degraded in the lysosomes. And so you have fewer LDL receptors circulating back to the surface. And this results in very high levels circulating LDL because the receptor is broken down. PCSK9 is attached to it. The Fourier trial looked at evolocumab. These were 27,000 high-risk patients who had a prior MI, stroke, or symptomatic disease. treated with statins plus or minus ezetimibe. LDL remained above 70 in the run-in period. They were randomized to either ezetimibe or matching placebo, given subcutaneously every 2 weeks. Primary endpoint was a composite of these cardiovascular measures, and the mean follow-up was 2.2 years. And within that period of time, there was a relative risk reduction of 15%, number needed to treat 67. And some of the individuals had LDL reductions down as low as 20 milligrams per deciliter. And there were no increase in side effects or toxicity measures in these individuals with very low levels. And in the Odyssey trial, somewhat similar, alirocumab, 18,924 patients who had a coronary event within the last 12 months, treated with statins and ezetimibe. And if the LDL was over 70, they were randomized either to alirocumab, placebo, and the same composite primary endpoints. Median follow-up 2.8 years. This looks almost identical to the Fourier results. Relative risk reduction 15%, the number needed to treat 63. And then we come to inclisiran. The two PCSK9 inhibitors we just described were monoclonal antibodies to PCSK9. Inclisiran is a first-in-class small interfering RNA, inhibits the hepatic synthesis of PCSK9, results in long-term reductions in LDL. The siRNA hepatocytes enters the hepatocytes by the interaction between GAL and AC, which targets acellular glycoproteins. And this enables it to have a very precise and rapid uptake in the liver. Then the siRNA is loaded onto a complex called RISC-RNC, which silences the messenger RNA it's attached to. Since there are only 100 to 200 loaded RISC complexes per cell, each complex has a very long half-life. And that's why you only have to give this drug every 6 months instead of monoclonal antibodies every 2 weeks. The first dose is given sub-Q, and then 3 months later, and then after that, 6 months. And this just summarizes the events. The GAL NAC targets to the hepatocyte. And then there's something called a dicer, which separates the antisense, incorporates it into RISC, which is then degraded. And so this is a summary slide. Small interfering RNA directed to PCSK9 mRNA. It is approved as an adjunct treatment to diet and maximally tolerated set. We do not have a clinical outcomes trial, but there are phase 3 studies, trials being carried out. So, summarizing the information about the PCSK9 as a therapeutic target, there's genetic evidence targeting it. A loss of function results in a decrease in LDL and a decrease in risk of gain of function. Gives pattern similar to that in familial hypercholesterolemia. There are 3 injectable inhibitors currently available: evolocumab, alirocumab, monoclonal antibodies, and then inclisiran, small interfering RNA. Uptake of injectables has been limited. Not talking about the uptake by the body, but the uptake by the doctors. These drugs have been very slowly catching on. The monoclonal antibodies use prescription experience was increased when they reduced the price of it by 50%. But inclisiran, which has been touted as sort of a vaccine against atherosclerosis. Its uptake has been pretty slow, below expectations. Now, bempedoic acid. ATP citrate lyase is an enzyme that catalyzes splitting of citrate to form acetyl-CoA. And this is, as I said earlier, 2 steps up from HMG-CoA reductase. It reduces atherogenic lipoproteins, hepatic fat, inflammation, attenuates experimental atherosclerosis, and improves glycemia in various animal models. And Mendelian randomization studies validated as a target. Just constantly look over on the right side of the slide. Citrate is broken down to ATP citrate lyase, and then that is inhibited by bempedoic acid. Bempedoic acid requires activation, and unlike the statins, it is not active in muscle. So it has to be activated in the liver, and this is postulated to reduce muscular side effects. When bempedoic acid is looked at in patients who are on statins, there's about a 15 or 16% reduction in LDL. But if you look at statin intolerant patients or patients who've never been on a statin, there's a 23.5 or 0.6% reduction. So you would expect it to be more effective in patients who are statin intolerant. There are various estimates about statin intolerance, but majority of overall, it seems that it's about a 10% of the population who just can't tolerate statins. It's not that it causes rhabdomyolysis, but they have a variety of effects. They feel pain or weakness in the muscles. They're not able to exercise as much. And so a trial was organized by Dr. Nissen at the Cleveland Clinic to look at bempedoic acid in statin intolerant patients. Bempedoic acid at 180 milligrams per day versus a matching placebo. And these show the various endpoints. But for example, for fatal or non-fatal MI down at the bottom of the left, there's a 23% reduction in fatal and non-fatal MIs. 13% reduction with a 4-point measurement of 4 points for that, 4-point endpoints, because there was not a reduction in cardiovascular death. But overall, in the other measures, there's a 20% or greater reduction in these events. So bempedoic acid has been approved by the FDA for reduction of cardiovascular events. And when it's given in a combination with ezetimibe called Nexletol, it gives almost a 40% reduction in LDL. But the mainstay of the treatment for the foreseeable future is still start with statins, and then as needed or indicated, we add something else. And it doesn't seem to matter how you lower the LDL, whether it's mutations in even C1 like 1, HMG-CoA reductase, PCSK9, ABCG5, and 8, or the LDL receptor. They all give about the same reduction per unit. 39 milligrams per deciliter of LDL gives a 22% reduction in cardiovascular events. Well, what about CETP inhibitors? Where do they fit in? Because it's been thought, and the dogma is that they don't affect the LDL receptor. And some contrary opinion has recently been raised by the New Amsterdam pharmaceutical company based on the drug I'll talk about in a few minutes. There have been a number of CETP trials, and the whole hypothesis is that raising HDL will reduce cardiovascular risk. And except for one, the one with anacetrapib, they're all negative. In fact, the first one, there was an increase in toxicity due to an off-target effect. So the New Amsterdam company acquired a drug called obicetrapib. And what the CETP inhibitor does is that it decreases the exchange between HDL and LDL or IDL of triglyceride or cholesterol ester. And so as a result, there's an increase, marked increase in HDL cholesterol up to 100% increase. Well, obicetrapib, simple oral once daily low dose inhibitor. Since this slide was made, they are now in a phase 3 trial. They reported a 50% lowering as monotherapy, although the recent results that were presented at the European Society of Cardiology show that much reduction. But it does have a robust effect on ApoB, non-HDL, and Lp(a), which is different from the other drugs I've been talking about so far, and it raises HDL. Just to go back, the New Amsterdam company claims that it also increases the LDL receptor. And that's why they get the reduction in LDL. So this remains to be settled. It's not settled at this time, but it's possible that this drug also could be entered into the list of drugs that work through the receptor, but we don't have enough evidence at this time to know one way or the other. And then Ezetimibe, this definitely doesn't work through the LDL receptor. It's an angiopoietin like 3 is a liver expressed secreted protein. It inhibits lipoprotein lipid, which means it would inhibit the conversion of VLDL to IDL and LDL. It's independent of the LDL receptor pathway, and inhibiting it results in lowering triglyceride, LDL cholesterol, and even lowering HDL to a small degree. Again, Mendelian randomization data suggests would be a benefit in lowering angiopoietin-like type 3, and it would be proportional to the reduction in ApoB. So it was tested in individuals who are homozygotes for FH who have no LDL receptor at all. And this was published in the New England Journal of Medicine. There's a 23% reduction in FH homozygotes with this inhibitor, which does not work through the LDL pathway. I haven't talked much about Lp(a) inhibitors, but Lp(a) is an independent predictor of cardiovascular risk. And since companies are running out of other targets targeted Lp(a), and their clinical trials currently underway, pelacarsen is a GAL-NAC conjugated antisense oligonucleotide directed against Lp(a). Alperesin is a small interfering RNA against Lp(a). And there is a drug, an inhibitor being studied at the present time, a small molecule, multileptin, which would be an oral inhibitor. None of these results are out yet, so we don't know how effective these drugs are going to be applied on top of statin therapy and other LDL lowering mechanisms. Finally, CRISP, clustered, nobody can remember. Clustered regulated interspace short palindromic repeat.
Social Security named cottage. Main cottage seat of security.
They had security call from our house in Maine. So, anyway, it's not important. CRISP has been used for gene editing. And it disrupts the gene, it can be used to repair the gene, unintended consequences. It's actually been used in patients who are heterozygotes or PCSK9. I'm not sure, I don't think these studies are been carried out in the US, but they were in New Zealand, and several patients who were heterozygotes were treated. You'd think they would have treated the homozygotes, but the vehicle they used to administer the drug didn't work well. Some bad interaction with the homozygote, so they use a heterozygote instead, and it does reduce PCSK9, but it's a little early to make judgments on this about how useful it will be. Lies on extensive complementary base pairing to locate a DNA target. So they make a small segment and use that as a guide and to go in the cell with the Cas9, which breaks down the DNA. So you have to be sure that the small part finds the right part within the gene. And 3 years now ago, this paper was published in Nature. Genomic analysis reveals atypical, non-homologous, off-target, large structural variants induced by CRISPR-Cas-mediated genome editing. So the concerns about it, knockout of the B2M gene by CRISPR-Cas9 genomic editing induces unexpected large structural variants in the chromosome, which is not good. It has promising therapeutic potential, but safety is a concern, I would say. Here in this particular publication in 2023, they used whole genomic analysis, and what they found was large structural variances in the off-target sites. So I think this is a case where stay tuned and see how this evolves. So my last slide summarizes emerging lipid therapies. LDL remains the primary target. Statins are the mainstay of therapy. There are several new classes of lipid therapies that are currently in development. New therapies target the protein or the mRNA, or in the case of gene editing, the DNA. CV risk reduction must be proven for these new therapies, and we're carefully watching out for adverse side effects with them. We still don't know what to do about HDL. So that's it. Thank you very much for your attention.
Thank you very much for the wonderful lecture, very inspiring vision of the future as well, and learning from the past. So please put your questions in the Q&A in the chat if you're on Zoom, or here we can go through questions in person. Dr. Monrad?
You know, I go back a little further than you went. I think you left out this significant part of history, which was the cholestyramine trial. And at the time, you remember, I see the pain and you're nodding in your head, because the editorial that the New England Journal put with it basically said cholesterol, the end of an era, which was quoted for the next 20 years by the pop literature for quite a while for why there was nothing you could do. And all your presentation would never have happened if people actually listened to that editorial.
Right.
So a certain caution needs to go even in reading medical literature, not just the internet. But you know, really what I was looking at, and I didn't see any hint of it through your data, is do you see any sign of a J point? Is there too low to go?
I'll repeat the question just for the audience. Is there any J curve or any lower, any risk in going very low with LDL?
None that's been identified. Gene Brownwell says he wants his down as close to zero as possible. But I would settle for something around 40, which is what you're born with. I was one of the PIs on the coronary primary prevention trial, which was very hard to carry out. First of all, you had to identify the males who were on diet had LDLs over 170, no cardiovascular pre-existing disease, and getting them to take 24 grams of cholestyramine a day was just not possible. They averaged about 12 grams a day. But there was a significant reduction in cardiovascular events by a single tail, not by a double tail study. So the cardiologist said, this is hogwash. This doesn't prove anything. No reduction in mortality. I happened to be president of the American Heart Association at the time, and if I hadn't been, the AHA would never have endorsed this study because the cardiology section of the AHA were totally against it. It really wasn't until 4S came about that the cardiologists came on board.
Thank you very much. Mike, I think you had a question.
Yeah, thank you so much for the talk. I'm curious your thoughts on using LDL particle size in your assessment of patients, or if you think there's utility at all, because it's sort of, I think, gaining a little bit of steam in some subgroups.
Right, they claim the New Amsterdam people claim that the obicetrapib decreases the small dense LDL particles along with the LDL. I don't know. I don't typically measure them. If the triglycerides are elevated, you know you're going to have more. The real question is whether or not the larger LDL particles that are produced are results of lowering triglyceride, whether they are atherogenic or non-atherogenic. But I do not, personally, I don't find measuring particle size that useful.
Do you think we should be lowering triglycerides to reduce cardiovascular risk?
That remains to be seen. First of all, that will be tested by, I didn't get into the anti-C3 studies, but I was chair of the Data Safety Monitoring Committee with Belporsen, which is an antisense inhibitor of ApoC3. And we're looking mainly at reduction in abdominal pain and pancreatitis, which is so uncommon, you can't get enough to get a clinically significant results. But there was a significant reduction in triglyceride, even in those individuals who didn't have any lipoprotein lipase to inhibit. So the drug worked, but the FDA was concerned about the decrease in platelet, which that antisense did. Now with the NGAL antisense, a trial has been carried out with that, and the drug is now approved. So finally, there is a drug on the market for familial chylomicronemia and severe hypertriglyceridemia. And so what the companies are going to aim at is if you get the triglyceride down under 500 with this drug, can you get a reduction in cardiovascular events? So that remains to be seen, but it will be tested. The one study with that showed a reduction in events in hypertriglyceridemia was carried out in individuals who had cardiovascular disease or without, but had a triglyceride over 150. And there was a reduction of about 25% in this trial, but none of the other omega-3 trials have been positive. So it remains to be seen whether this was just a fluke. And the reduction in events could not be explained on the basis of the reduction in triglyceride.
Thank you very much. We have a question from Carlos Rodriguez here on the chat. It says, thank you for your talk and all your work over the years. You bring up a great point on how will Lp(a) therapies interact with other background lipid-lowering therapies. Are current trials being done in patients on maximal statin therapy? Do you feel that statin therapies will have to be modified once Lp(a) therapies are on board?
The studies that I referred to with antisense and small interfering RNA, those are in patients who are on optimal statin and other drugs as well. So they have to look at something that's separate from the LDL, and LDL has to be under adequate control. So I can't predict how these studies will turn out. Lp(a) is a reasonable target. We know that elevated levels are associated with increased risk. But how much do you have to lower it in order to get a clinical benefit? Can you see a clinical benefit? These drugs that are being tested reduce Lp(a) by 80 to 90%.
Significant. I guess a question related to that is if you see individuals where the only risk factor is Lp(a) that is elevated, you start statin therapy right now waiting for those to counteract the effect, or you think we should just wait?
Well, there are a lot of clinics in Germany and a couple in the US that are using apheresis to lower Lp(a). So there are no clinical event outcomes with that, but it is being widely used, especially in patients who have what's considered normal levels of LDL and continue to have repeated events. In New York, the Roberson Clinic is treating quite a number of patients on the basis of elevated Lp(a).
So have to wait, Aldo.
Well, thank you for such an inspirational talk. Your career inspire all. Thank you for that. A little bit aside from cholesterol, but more in the inflammation, I just want to get your thoughts on colchicine. Do you think is a lot of debate recently? You think has a future in cardiovascular prevention or not?
Yeah, I think so. I have a 1 week course on lipids and metabolic disease in Salzburg each year, and it's funded by the Soros Foundation and the Austrian American Foundation. But anyway, there are 35 young doctors from the former Soviet Union and Eastern Europe, and they come together with half a dozen faculty members, and we're in a villa or a castle called Schloss Ehrenberg, and we interact for a week with them, with the young doctors, and they have case presentations, lectures. I give 3 myself, and and Dr. Filippo Crea, who's editor of the European Cardiology Journal, has participated as a faculty. He convinced me some time ago that colchicine was worth considering, would have some benefit. So the studies seem to be positive this time. But again, it's inflammation. And I didn't have time in my lecture to go through all of the studies about inflammation and its role, but obviously it is very important, and there's some evidence that I presented, some data shows it's independent of the LDL reduction.
Thank you very much. I think with that, we can close the Grand Rounds. We really appreciate your time, and now we can just talk maybe a little bit with the fellows or just help you get home. Okay, thank you.
Okay. Glad to sit, and if anybody wants to